So first of all, thank you very much, all three of you, for these very interesting, insightful keynotes, which I think showed also different perspectives on the topic of remote care. And your talk, Ellen, reminded me of a Zoom call I had last week with one of the panelists from Tomorrow, and I didn't meet him beforehand, so it was the first time I met him online. And then we started to talk, and it was my home environment. In the background, it's just a wall. But then suddenly I did like this, and then this new feature from MS Team came, and there were the balloons going up. And then after a minute, my cat jumped on the table and went like this and was going like that. And I was saying, I'm sorry, this seems to be very unprofessional. So I did every mistake that I could have done, although I'm experienced through COVID. Nirit, I'm wondering, you are an architect, you're working in a hospital, doing research on the impact of space. Do you see any changes in the way your colleagues at the hospital pay attention now to the physical environment? Is it an issue? Did it change how they perceived remote care?
Thank you. The hospital where I work in is really focusing on technology development. They created an innovation center where all the doctors, all the physicians can come up with ideas, and then they have this innovation platform to develop their ideas into startups. So this is really the paradigm where I work in, and they didn't think at all about the built environment at first. It was really surprising for them to realize that, you know, a lot of startups fail because they don't think on how it's going to be integrated into the built environment. And I'm really proud, first of all, that they are now using the terminology of evidence-based design. So they realize that there is evidence about how the built environment impacts the outcomes. But now when they are designing new spaces, where they say, well, we don't need any more waiting rooms, for example, because everything will be digital. The patient will not have to wait. They will know exactly when they have to be at the doctor's office, for example. So why do we need waiting rooms? But then they start thinking that maybe there are other aspects which are not taken care of only by technology. So maybe people need to meet, to socialize, to meet other patients, to have a different purpose for the space. So the technology impacts the way that we are using the space, but also the space will change how we use the technology. And they start to think about it. I have to be honest, I think we are not there yet. It's really all about the technology, but they are starting to think about it. Also, there is this interesting project designing new clinics. And they realize that it has to be hybrid. So sometimes the patient will come in person and sometimes the patient will be virtual. How do you design for that? Like you showed examples, but how do you manage this hybridity? And it has a lot to do with their perception of how you should focus on technology and not so much about the space.
Talking about the technology, Paola mentioned before, the question is still for Nirit, but you can maybe also answer it. Paola was talking about the inequalities in the use of technology, and I was wondering, when you were doing your research in the hospital, you were talking mainly about the patients, but looking at healthcare stuff, is everybody open for new technologies? Do they embrace the possibilities, or did you observe other things?
A lot of resistance. A lot of resistance. I think that in general, I would say the patients were much more open to be treated remotely. They saw the benefits of, you know, not having to come to the hospital, taking the day off, finding a parking space. They could stay in their natural environment, either in their workplace. The privacy in the toilets, I think, is a good example, but also at their home. But the physician suddenly realized that there was this lack of control that someone mentioned. Because, you know, when someone enters their clinic, there is clear hierarchy. You know, you're coming into my space, and now I can kind of control how the interaction is happening. But once it's remote, a lot of it is out of my control. Some of them actually said that they learned a lot about the patients by seeing their natural environment and seeing the family members. So a lot of things that we mentioned as challenges were also beneficial for the diagnostics. Someone said something very nice, that when a patient enters their clinic, it takes a lot of time for them, in the context of mental care, to take a lot of masks off until you get into the real persona. But sometimes when they see the patient remotely, they have a better understanding of their natural condition, so they have less masks on them. But yeah, there is a lot of resistance, and we should also mention there is a big difference between nurses and doctors. So the idea is that the doctors communicate remotely, but the nurses will come to the patient home physically. So again, it creates this hierarchy, which was always present. But I think when we think about hospitalization at home, it becomes really an issue on how you manage these differences between the different professions.
And one extreme example, you were mentioning, Paola, about inequalities in the use of, or the accessibility of digital technology. You were talking about marginalized groups like asylum seekers or homeless people. And Ellen showed a beautiful example from the library. So I was wondering, we are talking now during the symposium about remote care at the hospital or at the home, but there is still the remote care at the community. Might this be a way to give these marginalized groups more access to technologies, remote care? What is your opinion on that?
I think it's definitely the way, one way forward. People who might, I mean, in the case that we were examining, it was a little bit like extreme, because of course for asylum seekers, you might be very much like new to a place. You might be moved and allocated in a different in a different regions where maybe your contact or where you initially arrived. So even knowing what social resources, what community resources are available might take some time. But the example of the library I thought was a great one, because libraries are in fact places which are way more accessible and are used by many people, also people that might have social or financial hardship. And this is like, it could be a place where actually many people already go to access online, in Wi-Fi, online technologies. And I think it could be a place also for remote care. It will still require sometimes for those who are new, in my case, to learn what is available, but also it might require still sometimes to get a trust on knowing the place and knowing how it's accessible. But it would be definitely one way of like making digital technologies and remote care more accessible. So that would be an interesting way of bringing it into the community. Libraries are great places, but looking at where these people already go would be another interesting way to approach the issue.
You were also mentioning participatory design. I was wondering, like, what do you think? How do you think that design or design research tools can help to build? You mentioned confidence rather than trust. So, what can design or design research tool play? What kind of role?
I mean, I was hinting at some of the roles, and I think one is definitely like not just looking at designers as the ones that can provide a solution and design the thing or the space, but actually thinking about designers as design researchers and understanding how they can help really capturing the problem in its, and what are the issues that we're trying to address, and how different people may experience different issues, including regarding issues of access or levels of access. Unfortunately, there's still very little user engagement or participatory design. I want to definitely call it participatory design more than just user engagement. There's a lot of user testing. So these things are tested with real users, and that is one level, but I think the participatory design angle would require designers to engage the different actors involved, so of course not just the patients, but very much from the beginning, from deciding what are the requirements of the technology, what are the issues that this technology should be addressing, and what are the needs of a diverse population, and how can we, as much as possible, accommodate for most of those needs. And I think still this kind of more holistic understanding of design beyond user testing, I think is still limited. Especially in healthcare design, and especially in the design of digital technologies.
You were mentioning, rather than talking about building trust, you said confidence. Can you maybe elaborate a little bit what brought you to the idea that confidence might be a better term?
I guess what I was hinting at is the idea that when it comes to designing for trust in technologies, there might be an assumption that we want, as designers, we need to play a role in increasing acceptancy. And I think this is important, but I would like to imagine that designers also have a role in raising information and perhaps also some questions that patients might want to ask when they are told to use one or another type of digital technologies for remote care. So the idea is that trust is fundamental in healthcare among people and is an interrelational thing that happens between people when it comes to people and technology. I'm wondering if trust is the right word, and if trust is exactly what we want, if we want people to always, without questioning, trust the technology, or whether we might want people to raise some questions regarding, for instance, who is proprietary of the technology that I'm using, where is my data going to be stored, and how is my data going to be used. I really like the Nirit example of the surveillance camera. And again, a confident patient might ask, is that camera always on and is always recording me? Can that be switched on? A trusted, maybe patients might not even ask that question. And we want, or at least I hope we should aim to get to that type of patients that ask the questions of how is this technology that they're using working, and could that work differently for them to have more trust. So that's the confidence.
I just want to comment on that. You mentioned the gaze angle. You know, there is technology that can make it looks like you're constantly looking at the camera, although you're looking at something else, looking at your cell phone. I don't know if you know it, there is an app that can manage that it will always be as if you're looking straight to the camera. But then, does it build trust? I think we will lose trust if we know that this is something that is being used.
Yeah, I think the technology, and you had mentioned, where's my data going? So, you know, if you have a Fitbit or an Apple Watch, there's incredible things that you can get through that. Fall protection, you know, heart rate, I'm having atrial fibrillation. But again, the data is going somewhere. And many years ago, when the Fitbits were a little bit newer, a friend of mine had foot surgery, and her physician told her, you know, you need to stay off your feet for X amount of time. And I know that you exercise a lot, but, you know, you're going to need to take it easy. Oh, and by the way, you know, can I be your friend on Fitbit? Like, that would just be great. And she didn't even think about it. So she made him a friend. And then she did what most professionals would do, which was, I have to work, so I'm going to go on this trip, which means I need to take a plane, which means I'm going to walk through the airport, forgetting that she had friended her physician. And she got to the waiting area and she got a phone call, and he said, it's really interesting. I just saw that you had about 8,000 steps. And I know where you would get 8,000 steps is going through Terminal 4 at LaGuardia. So tell me that you're not traveling right now. And she. So again, where is your data going and how is it being used? That could be a good thing, it could be a bad thing.
Ellen, one thing that you mentioned, I mean, you obviously are trying to set up minimal standards for environmental factors using telemedicine, telehealth, but at the end you mentioned that I think it's an accreditation program for telemedicine, that they don't mention the environment or space in one word. Why do you think is this still the case?
So even with FGI, so I mentioned we had just had a recent meeting. It's called an all-hands meeting where there's more than 100 people that get together. There's a very good chance that the entirety of the telemedicine section will not be in the 2026 guidelines because there is a perception that it is just about the technology. And the more advanced the technology gets, the less the environment matters. I would argue that that's not the case. We still need to figure out how the environment matters. And I think part of the challenge, and I think the benefit of being able to do simulations is that people make an assumption that the environment is a given, that we can't change it, and that we just work around it. And I think to the extent that we can get people used to the fact that the environment is a variable, we can change it. It doesn't have to be the way that it is. We can start to shift that. But again, I think people just tend to fall back to it can be the technology that can address everything.
And how do you think, I mean, obviously we're a lot of designers, architects and so on, but there are people who are developing these tools and working in the healthcare services who are non-designers. But how do you think can we as designers and architects communicate to non-designers that design and architecture has an impact? So what could we do? And maybe it's also our fault that we don't communicate clearly.
So I think part of the challenge, and you know, it's wonderful that we have this group of people here today and that we're going to be able to do some workshopping together, but it's really also infiltrating other groups. So we have a volunteer group called the Environmental Standards Council. It's been part of the center for basically the entirety of the center's history, and it has been traditionally focused on the guidelines. But most recently, they've started looking at this blend of the physical and the digital, and they've termed it the phygital environment, and they are trying to figure out how to speak at the HIMSS conference, how to speak at some of these other technology conferences, because when they talk to people who are in the world of technology and start to talk about the implications of design, there is a light bulb that goes off, but it's been so siloed that we just need to figure out how can we do more than speaking amongst ourselves and really make sure that we get out to other people. But forums like this create more of an opportunity to then share with everybody else, here is the enormity of what we found. So I think we just need to keep knocking on the door or pounding on the door.
And I want to try that because we have also a lot of people not from architecture and design, but from public health, from nursing, from medical informatics. And I want to open the plenum and ask for questions from the audience. I see Stefan being the first one.
So I'm sorry if this was addressed at the moment. I quickly had to leave and make sure it doesn't get too loud. There's solar panels being delivered. It's a good thing, but happening at a bad time, obviously. So I had to put a stop to that quickly. So if you addressed this already, please excuse it. But in your study, Ellen, where you looked at the different backgrounds, the effect this has on the trust and confidence we put in our partners, did you look at the effect it has when we see each other? Because I found this the most irritating part of every Zoom or Teams meeting. And trust me, I don't look at myself out of some narcissistic notion. It just highly irritates me. And thank God most of the programs allow you actually to click yourself away. But has there been any part of the study focusing on that? Because it's really unnatural for us to have a conversation with someone and basically having a mirror focusing on ourselves as well.
So I want to clarify, that's not my study, that's somebody else's study. And they specifically did not look at other people, per se. The challenge with a lot of the studies, it's typical of research. You're able to study a very narrow slice of something to define a specific area, and then that allows the next group to then potentially look at the next thing. So maybe somebody will develop a study around that. There's confounding issues even with that study, and part of it has to do with testing the faces that you're using in the photographs to look at perceived attractiveness. How does that start to influence everything? So there's a lot of different things at play. And I think one of the other things that happens, and we talked a little bit about it in terms of people being able to see the background during COVID of your real home, a lot of the studies are done with fixed images, and we're very rarely that fixed image. So our facial expressions change. There's other things that happen. The cat jumps up in the middle. Sometimes that creates a nice moment where everybody laughs and, you know, breaks the tension a little bit. But I think that would be an opportunity for future work to really look at what is that dynamic of many.
Maybe I'll just add something before we move on to the next question. We're missing the body language when we are, you know, in the Zoom or Teams slot. And I think this is something that we need to develop. So there is development into virtual environments with Meta or other where you choose like an avatar for yourself. And then again, this confidence of how real is it or how much is it imagined? How will we want others to pursue to preserve our personality? How much are we really open? But I think there is a lot more to develop in this field, also in the design of virtual environments, not only in the physical environment.
Thank you all so much for your presentations, very thought-provoking and interesting. I had a question addressed to all of you. We talked about telemedicine or remote care in the hospital or at the home, but there is this whole other space in between, which is the ambulances that bring care to the home, both physical care and now increasingly virtual care, and provide care in transit, which is becoming really important. How would some of these issues, I mean, we've done some work and we found that there are some major issues because you're trying to provide diagnostic care in the ambulance, at the same time connect to a virtual doctor who's somewhere else, and the dynamic of both the space and the technology is very complicated. Any insights that you all have in the context of each of your work to add to this conversation, how it fits in the future?
I'll jump in. What I find really interesting is that there is this potential to change the way that we perceive the patient journey even. Because before the patient had to go to the ER, wait for hours to be diagnosed and then move between different disciplines of care. And now you can do a lot of it remote before the patient even gets to the hospital. So again, do we need those big waiting rooms in the ER? How can we design it in a different way? And one of the things that we realized that it's mostly the hybridity which is challenging, because you have to have like physical encounter, but also virtual. And then sometimes the setting for the virtual encounter are in conflict with what you need in a physical place. So yeah, I think the ambulance is a great example of how you can use technology to really shift where care is provided and maybe avoid even hospitalization or the ER waiting time.
A lot more work is needed for the human factors. How do you know, the concept is there. How do you make it work?
So I think one of the particular challenges in that environment is it needs to do so many different things, and you just don't know what you're going to need to provide. And I think it's an interesting point to the extent that technology has evolved to a point that maybe you don't even need to go to the hospital, that you can do all that diagnostic in the space. I think it ultimately ends up in a complete paradigm shift about what the interior of the ambulance looks like. I mean, this is a model that has been around for decades that was not based on what we have today. So it would be fascinating to sort of look at something that completely strips the ambulance of everything. And in the work that you've done, I mean, the ultimate human factors of work is imagined versus work is done, figuring out what really happens and what does the space need to do to support that service, rather than this is the way the ambulance has always been designed. This is how we think about what happens in an ambulance that may be 3 decades old at this point. So it would be interesting to take an ambulance and just strip it and see what happens using scenarios and try and figure out, okay, here's a scenario that happens 90% of the time. Somebody calls with symptoms of a heart attack. We need to do an EKG. What does that look like? What happens when somebody calls with symptoms of a stroke? What happens in, you know, a 5% clinical scenario, and then how do we then say, okay, then what do we actually need to design to support those activities? Go for it.
Yeah, thank you very much for 3 so interesting lectures. I was thinking about your examples, Nirit, from the pandemic situation, where you had one example from intensive care units and one from internal medicine, and you also mentioned mental health. And I think in mental health, it's especially important with communication and to understand and interpret your environment. And what was the lessons learned?
It was a failure. It was really, really interesting. What worked very well in the ICU, because it was a different level of care and it was really in the control of the physicians and the nurses. In the mental health, and again, it's a closed mental health with high-level psychiatric care, people who are in danger. They were dependent on the engagement of the patients. So if the patient didn't want to communicate remotely, then there was nothing they could do. So they actually had, at the end, to put on the PPE, you know, the protective gear, and move inside in order to have direct communication. There also was a lot of vandalism within the unit, so they had to protect the cameras. They had to put them higher so the patient will not be able to reach them. So suddenly the height became an issue because there was no, you know, straight line of communication. They had to stand and, you know, speak to the ceiling. So that it was really a failure in that sense. But it's interesting because when they developed the home hospitalization for mental care, for mental health, they took a lot of the things that they learned in that experiment with the COVID mental health unit, and they implemented it for the patient's home. So they developed this device that it has always to be in high level, in the eye level height for communication. Like different lessons that they learned, they later employed them at the home.
Thank you. Maya Zungstein. I'm from the Department of Health. I'm the Deputy Head of the Master of Science in Nursing program. And I have a question actually to all 3 of you. Thank you for your great presentations. I really enjoyed them. One of the issues I find are rarely taken into account when we talk technology and technology interfaces and AI or whatever not, is that most of our studies in nursing actually, and also medical studies, finally conclude that there is a very personal aspect to the whole patient-provider interaction, for example, of something called the therapeutical relationship. Have you found in one of your studies that this impacted by introducing devices, and in what way?
Maybe I'm going to start. It's not from my own studies, but I think there's enough research out there that actually shows the risks, or one of the risks of remote or digital health is exactly that you lose like the one-to-one personal relationship. And I don't think it's like, I mean, especially talking about mental health. Mental health was on the rise during COVID. And that was also partly due to the fact that we couldn't have personal contact with people outside of our homes or outside of our usual circles of family and friends, which was really reduced at the time, of course. So I think it was us even telling us something about the importance of establishing those relationships for our mental well-being, including, of course, in healthcare relationships. So the importance of having personal one-to-one conversations with nurses, for instance, and having that kind of physical touch. But one thing that I think is also very important, especially in mental health, and the type of mental health I was doing was, of course, less medical, as I was trying to share a little bit at the beginning. And a lot of the work and the support that people were having, we were not talking about patients, we were talking about people with experience of mental health, was the peer-to-peer support. So it was the support that you get from other people who are experiencing what you are experiencing, or just went through a similar experience or episode of schizophrenia or depression or whatever it was the condition. And I think this is also really interesting. And Nirit, I think you touched very briefly on that, how you lose or risk to lose with an all remote care setting the possibilities to meet other patients who are sharing your own journey. And this kind of exchange and contact and relationship is also key, I think, and is also perhaps a danger when remote care is not designed in a hybrid way, but it's actually the only care that you receive.
I want to build on that. I think for a long time we've been focusing on what can we provide remotely. So everything has to be physical, and then what kind of services can be remote. I think we are probably since COVID realizing that almost everything can be remote. You'll be surprised, but a lot of the healthcare services can all be remote. But then we have to define what needs to be physical in person. So when does the patient really have to come to the clinic or to the hospital? And in many ways, it has nothing to do with the medical treatment. It has a lot to do with the social support. So if we just, for example, think about why people went back to the office space, when we learned through COVID that we can communicate remotely from the ease of our homes, people still wanted to go back to the office to get inspired, to have this social interaction, to have inspiration from other colleagues. So it's not really about doing the work. It's for other more, I would say, soft aspects, and it will be the same with medicine.
And I'll add, so this is just an anecdotal example. A colleague during COVID ended up having a telemedicine appointment with a physician that she didn't know. It was, the next in line kind of thing. And it was not a terribly positive experience for her. And part of it is just a lack of familiarity with the technology, with who you're speaking to. Several weeks later, she had a follow-up visit with her own physician who had finally been set up with a telemedicine platform, and a completely different experience, a very positive one. And I think it ties into not only a familiarity with a person, that you're building that relationship, but you've been in that physical environment before. There is that controlled aspect, and now I have that as background. I know more about my caregiver because of all of the other things that happen as part of that system that then translate into the ability to do that virtual visit. I mean, the thing that happened during COVID with everything virtual was pretty fascinating, and there was a lot of stuff that happened with music. And I just recently went to a concert where it was the first time that these two performers had performed together live, because they met each other during a virtual gala during COVID, said, hey, I really think what you're doing is kind of cool. I think what you're doing is kind of cool too. Hey, why don't we do things virtually? So they managed to do all of these things virtually, but then the dynamic is very different when you're in person. And of course, you're in person, you have an environment with acoustics, and it completely changes how you're interacting with each other. So it's not that it's not possible, it's just how do we build on that to really create the most positive experience for people.
I have a follow-up question to Nirit. When you mentioned about the acceptance of and the use of technologies in the hospital, the telemedicine, the robots, there were some hints at different usages of along skill lines, along professional lines, and gender lines, but you didn't follow up on why, like reasons how you explain these differences. Like, why is the chief, the director of a clinic using the car and the robot, but other professions, genders might not use these technologies? And I wanted to ask, what you were thinking about that.
Yeah, well, I find it fascinating. I'm not sure that I have all the answers. I think it's really a field to explore, but I see a lot of differences between gender and also between nurses and doctors on adopting technology, on developing technology, on how they perceive, again, this confidence of using the technology. I think it has a lot to do with the organization culture. The hospital where I'm working is really promoting the doctors to be innovators, to be leaders in healthcare transformation. They are perceived as innovators, where the nurses are the ones that have to do, the hands-on work. So if a nurse comes with an innovation, then it's something very unique. It's not common. So I think there is a lot of opportunity to change this kind of cultural perceptions, and I think, again, I'm trying to lead this program for innovation in nursing, because I think there is so much knowledge, so much opportunity to develop new technologies around nursing. But it requires an organization cultural change. And it has a lot to do with hierarchy. A lot of hierarchy, like the directors are, leading, and if the director is resisting the adoption of technology, then the whole unit will resist. So it's really, the dynamics in the organization is really crucial to study.
So thank you to all three of you. It was very interesting. I'm not sure for who the question is, but I think, Nirit, you also talked about waiting rooms. And since we have that in real life, and it's not just a place to wait, you also said it's also a place to meet other patients. But in real life, I don't really remember going to a doctor and not having to wait. Usually it had a delay, and for whatever reason. So this probably also happens if we have appointments online, right? Delays. And that probably doesn't instill trust. I'm not sure, maybe a patient then thinks, oh, maybe they have forgot about me or whatever. And there's no way to go to the reception and ask, what is going on? When is it my place? And so are there any solutions or approaches to really having digital waiting rooms, or just to solve that kind of uncertainty for patients?
So I think that's there are many layers to that question. So I think, at least in the United States, there have been many organizations that have tried to use lean. Waiting is not a value add, so how do we eliminate that? In addition to just having that socialization of being around other people, there's many patients that are traveling with a companion, a family member, a friend. So you need to have waiting, and organizations that have eliminated waiting rooms have just found that they've put waiting in other spaces. So a distributed waiting model, because there's other people that are there. The whole concept of a digital waiting room, so I'll share a personal story. So my husband recently went to his physician and ended up waiting for about an hour and a half. And it's one of those, why is it that I am always on the receiving end of all of the bad things that have happened in your day? So again, not trust, not confidence. And his blood pressure was up as a result. And now the doctor is saying, well, we need to put you on medication because you have high blood pressure. Do you think that my blood pressure might be possibly influenced by the fact that I've been waiting here for an hour and a half in an unpleasant environment waiting for you? In the digital world, I'm not quite sure how that translates. There's still that lack of, I'll say, a lack of respect for one person's time over another person's time. So how does that get managed? Is it a situation where, your anticipated wait time is 45 minutes and we'll give you a call when you come back, but you're still hampered by what you can do because you're not sure when that callback is going to happen. So I think there's a lot to really still look at. I think the study that I had referenced with the smart waiting room is interesting to try and figure out if we just assume that waiting is a given, regardless of whether you're in a physical environment or in a virtual environment, can we use that to our advantage to somehow use wearables, to use remote devices to try and figure out what might be happening with that person, so that I'm taking the blood pressure when I first check in, an hour and a half later, my blood pressure might be higher, but I had that baseline from 90 minutes ago. So I think there's different ways that we can just start thinking about how do we use waiting in a different way than we've conceptualized it in the past.
Sorry, maybe just to add, I'm involved in a project designing new waiting rooms in the hospital. And one of the things that we realized that if you have this app that tells you that your appointment is delayed and you will have like 45 minutes and you can go to the coffee shop or you can go to a walk in the park and you will be alert, not that you now have to enter, but you have like 5 minutes ahead or 10 minutes, you can even choose. It empowers you and it gives you an opportunity to maybe not stay in the waiting room and get stressed and annoyed that you are just sitting there. And then how do we design the waiting rooms for different purposes, for different functions? So if before, we had chairs like you're sitting, now we might design the space to have like more of an interaction, like more like a living room spaces, or maybe areas where people can work, put out their laptop and work, or even we have a nice area where people can play chess or other games to enjoy, the social aspects. So we have to design the space in a different way using the technology that allows, people to behave differently. It's a change of behavior.
Thank you very much. I have to play the bad cop because we are heading to lunch and we have a tight schedule for the afternoon. Thank you very much, Ellen, Nirit, and Paola, for your speeches and for this discussion. And thank you all for your questions. You're very welcome to stay for lunch, and we are all there. So if you want to follow up with questions, please feel free to approach the 3 experts, but also leave them some time to eat. And but those of you who will join the afternoon from the International Advisory Board and the Scientific Board, we will continue at 2. And the other guests, you're very much welcome to join us tomorrow afternoon for the public session, and then we will also tell you a little bit of what has been going on here and how we further developed our discussions about the role of design in building trust for remote care. Thank you very much.